Good morning or good evening to everyone, and welcome to this webinar hosted by the Fujita Health Alumni Association. Today we have, as usual, two speakers, two dear friends, and I will introduce them later, Professor Giorgio Palandri, Dr. Michael Lumintang. We have, of course, our mentor and leader, Professor Yoko Kato, and we have two commentators, Professor Ashish Kumar and Professor Kurosaki. We also have two discussants, as usual, Dr. Sukirti Chawan and Dr. Shavanas Biswas. Thank you to Raja and Liu for helping us with the logistics, as always. Before introducing our speakers, I would like to ask Professor Yoko Kato to give us a few words to introduce this meeting. Good morning, Professor.
Good evening. It's
Good evening there, yes.
Okay. So anyway, thank you very much for the Professor Giorgio and also the Mikhail. Thank you very much for joining and also give us a good picture, I think. So today's we have a special commentator. I asked him this morning because he is a specialist of the PitNET, the pituitary lesions. Maybe he may give us some great comment, I think. So we are very much looking forward to guest speakers' talk. Thank you very much.
Thank you, Professor. And I forgot, of course, to mention my co-moderator today, Professor Tushit Mevada. Thank you very much, Tushit, for joining. You will help me with the discussion time and also with the introduction of our speakers. We can start with the first one. It's a real pleasure for me to introduce our first speaker, Professor Giorgio Palandri. Giorgio is, first of all, a dear friend of mine, and he's also a very renowned colleague. He's a consultant neurosurgeon at the Institute of Neurological Sciences of Bologna in Italy, where he leads the multidisciplinary program on idiopathic normal pressure hydrocephalus. And he obtained his medical degree cum laude from University of Parma and then completed his residency at the University of Verona, actually a few years before I joined Verona University. And he also spent some time as a visiting clinician at Hôpital Lariboisière in Paris with Professor Bernard George, and later at the Mayo Clinic in Rochester, USA, with Professor Lanzino. He is author of more than 100 peer-reviewed articles, especially in the field of hydrocephalus, brain tumors, and spinal neurosurgery. He is founder and principal investigator of the Bologna Pro-Hydro Study Group, which is an internationally recognized team focusing on clinical, radiological, and biomarker characterization of INPH. He has important international roles, especially in the Hydrocephalus Society. He is the president of the Hydrocephalus Society now, where he served before as secretary and treasurer and scientific chair. And he is also a core member of the CSF section of the European Association of Neurosurgical Society. And he has many clinical and scientific expertise, including hydrocephalus in adults and cerebrospinal fluid dynamics, intramedullary spinal cord tumors, neuro-oncology, neurophysiological monitoring, and neurorehabilitation. Today, Giorgio Palandri will talk about normal pressure hydrocephalus, key concepts for the young neurosurgeons. I thank you, Giorgio, especially for choosing a very important topic focused on young neurosurgeons, which is the main aim of our Fujita Bantane Alumni Association webinars. Thank you, Giorgio, and you can start and share your screen and presentation.
Thank you very much. Thank you very much for having me here. I'm really honored to be here, and I think it's very important for us to be here together and to share these concepts together. I think you can see my screen now.
Yes, we can.
Okay, thank you very much. Speaking of hydrocephalus, and not only normal pressure hydrocephalus, I think it's important that we raise a new generation of neurosurgeon, and I will try to find out some key concepts for them. As you mentioned, we are not alone. There's an hydrocephalus society dealing with this problem, and please always keep in mind that Hydrocephalus Society is a worldwide society, so you can join that. I have this conflict of interest, and as Alberto said, I live and work here in Bologna, which is, I would say, in the middle of Europe. So if everyone wants to come and visit us, please feel welcome. This is the coat of arms of my hospital. This is actually the hospital, which used to be a villa in the past, and it was donated by the mayor in 1900 centuries to the city as a sanatorium, and now it is an hospital. This is the old entrance of the hospital with these two beautiful statues, and opposite to that there's this new pavilion, a new one. We have the ward here, and the ORs are in the underground. So I think we should be honest. In many ways, hydrocephalus is still commonly believed to be a simple subject for simple minds and left-handed surgeons. At the end of the talk, I would like you to understand my point of view. In my point of view, this is a very complex subject. It is only for smart guys and should be handled by an experienced team. The first false myth I want to show you is that not all hydrocephalus, not all adult hydrocephalus is IMPH. For example, this is a 72-year-old woman with the biventricular hydrocephalus. You see that the third ventricle is occupied by a lesion, and lesions are everywhere within the lateral ventricles. And for example, an experienced surgeon can do an endoscopic biopsy, do a septostomy, and put a VP shunt in just one procedure, and obtain, of course, an anatomopathological and histological results, and let's say cure this woman. This is another case with an obstructive hydrocephalus due to a colloid cyst. This is a 32 years old female, a young mother, which came to our attention on a Sunday afternoon with this acute hydrocephalus. She immediately performed this MRI. We were able to remove this colloid cyst, and this is a long-term follow-up of a very well and young mother. This is another case of a 65-year-old woman. Actually, she is the mother of one of our doctors in the ward. She was admitted with obstructive hydrocephalus due to this partly calcified lesion. We did a a third ventriculostomy with the biopsy. Unfortunately, the biopsy was not conclusive. We sent her to a 6 months follow-up. The lesion enlarged. She was well, but we decided to operate upon because the biopsy was not conclusive. And this is a 3 years follow-up. She was treated for an anaplastic astrocytoma. From time to time, you can have monolateral foramen of Monro stenosis, which can be handled through endoscopy too. And from time to time, more rarely, you have a bilateral foramen of Monro stenosis. This is a case referred to us from our neurologists who were treating this young lady for many years for cephalalgia. And you see, we did a septostomy, and this is the foraminoplasty of the foramen of Monro. Even more rarely, you can see a bilateral foramen of Monro stenosis and aqueductal stenosis associated. This is a 67-year-old man, again treated by our neurologist for cephalalgia. You can see this is a 7 years previous MRI showing a moderate enlargement of the lateral ventricles, maybe an aqueductal stenosis, even if Alberto maybe would not be completely in agreement with this statement. I learned a lot from him. And this is what happened 7 years later. He came to our attention with a decompensated hydrocephalus, and you see lateral ventricle are much more enlarged, and here you can see clearly a stenosis of the velum interpositum, maybe. This is the video of the foramen of Monro occluded. This is the endoscopic management with the foraminoplasty. Of course, we have an high riding basilar artery, so the ETV is not completely easy here. However, we did it, and this is again a long-term follow-up, and again another case of aqueductal, a pure aqueductal stenosis, again treated by our neurologist for many years. This is a previous MRI with showing for a 20-year-old male, I would say a modest enlargement of the ventricles, but unfortunately it came to our attention with a subacute hydrocephalus. Now the stenosis is more clear, and again a long-term follow-up after ETV. You can also have a fourth ventricle outlets obstruction. This is a case of a 32 years old woman with nausea and vomiting for many months. Then she arrived in a comatose state to our attention. We placed an EVD, and then we performed this MRI in which you can see the nice image of the foramen of Luschka and Magendie dilatation. And again, this is a long-term follow-up of this young woman. This is another case with the subacute obstructive hydrocephalus who came to our attention. We performed an MRI. The patient was not perfectly cooperant, and you see there's an obex imperforatum with the syringomyelia, and this was successfully treated with an ETV. But when you deal with hydrocephalus, your colleagues start referring you patient and this is important for young neurosurgeons, even with the pathologies within the ventricle not really causing hydrocephalus. For example, this is a 65-year-old woman who fell at this subdural hematoma, but we could easily spot something within the left ventricle. The hematoma resolved, but the lesion is there. Then we start performing MRI. The lesion is growing. We discuss option with the woman. And this is what we did with an endoscopic, minimally invasive procedure. And this is the woman more than 15 years later, recently at the follow-up. Another false myth is that shunt is a very simple procedure and that shunting has no or minimal complication. For example, this is a 40-year-old female. She had a ventricular shunting in childhood and a revision, a ventricular peritoneal shunt in adolescence. This is a CT scan in 2013, only with headache. We didn't do nothing, but of course the overdrainage was clearly present. Then she presented to our attention again with headache, but this time in 2019, the ventricular system is clearly dilated, so the shunt is not functioning. The ideal thing to do would be to revise directly the shunt, but we safely put an EVD, and then based on this aqueductal stenosis, we decided to try to perform an endoscopic third ventriculostomy, and you see this posterior thalamic vein, a very hypertrophic plexus, not truly clear anatomy in which you can understand where to do the ATV, and we performed the ATV, and then we decided to try to free the catheter. I mean, you see the adhesions here. You could easily imagine what would happen trying to remove directly this catheter. And this is the end of the procedure. This is the ETV working until now. The woman is doing fine. And what happens if you have already 3 catheters and a colleague of yours decides to put the 4th one? I mean, this could be truly a big problem and a big mess. And to shift from this picture to this picture, it took me more than 20 procedures and 4 months of hospitalization. But regarding IMPH, we are now more than 60 years from the discovery of IMPH, and in the very beginning we had a very young medical doctor, Professor Arkim. We had a very high risk operation. We didn't have programmable valves, we didn't have anti-saphron devices. This is how it started. And after 60 years, I must say that thousands or doctors and research around the world are dealing with hydrocephalus, and we have hundreds of thousands of treated patients, and we had a huge reduction in risk and increasing life expectancy and quality of life of treated patients, also thanks to the introduction of new shunt technologies. Are we on the right path? We can say for sure that it is underdiagnosed and then undertreated. But the fact that it is undertreated is not only a consequence of the fact that it is underdiagnosed. Again, let's be honest, there are many people still not really involved with hydrocephalus. For example, even at the European neurological meeting does not exist a topic nor a session on hydrocephalus. And we had the first meeting at the Geriatric Society last year for IMPH. I think we should build a multidisciplinary team around our patient. I think it's truly most needed. To do this, I think that we as neurosurgeons, we truly need for a change of mindset. This is my friend Roman. This is due not only to skepticism, but also to the fact that neurosurgeons consider this pathology not truly exciting, sometimes time demanding, because we need, as I told you, a multidisciplinary team. We need a tailored projects, keeping into account patients' expectation, and we need long-lasting multidisciplinary follow-up. In 1992, Professor Van Neste published this paper in neurology, stating that the overall morbidity rate of each patient demonstrating meaningful improvement is high. So he was doubting about the utility of surgery for this patient. And this was later on confirmed by the systematic review by Haben Cusimano, and 22%, this was published in the years 2000. Still, we had 22% of revision surgery with 6% of permanent neurological deficits and death. Is this only a problem of the past? I don't think so, because in 2021, Payat published this paper. In 1 year in the US, they had 67,000 admissions for hydrocephalus. Of these, 48,000 were index admissions for hydrocephalus, and this resulted in more than 8,000 of revision surgeries for hydrocephalus. And again, this is not a problem of children and infants, but is mostly a problem of adult and elderly people. And of course, there are non-believers. This is a paper published in 2017, deconstructing normal pressure hydrocephalus ventriculomegaly as early sign of neurodegeneration, published by Alberto Espe. And the editor-in-chief commented, "Is there even such a thing as IMPH?" Because in their experience, only 36% of the patients had a sustained response at the 3-year follow-up. Did we do our homework? Well, I think so. If we see the percentage of improved patients at 3 months, 1 year, and more than 3 years, during the decades, we have definitely improved our performances. And regarding the shunting over the 80s, these are elderly people. Sorry about that. We definitely had an improvement, raising during the decades, and we definitely diminished our complication rate. Of course, all that glitters is not gold, because we are focusing on primary shunt, not on revision cases, and this kind of data come from teaching centers, and it's not really a true mirror of what happens in real life. Right now, we have also the PENS trial, in which they confronted an open shunt and a placebo at 3 months, and they were able to demonstrate that an open shunt definitely improve gait velocity, while a placebo, that is to say a closed shunt, is meaningful for a deterioration of the gait velocity in 3 months. Everything seemed quite clear in the past. We had an Hakim triad symptom, we had ventriculomegaly, we had a positive TAP test, then everything which remained to do was a shunt, a very easy procedure. But then, what about incomplete triad? What about comorbidities? What about movement disorders? What about dementia, clinical assessment, and again, ventriculomegaly? What about obstructive? What about secondary? What about vascular atrophy? What about new MRI techniques? And what does it mean to have a positive TAP test? How much CSF should I withdraw? Which are the correct interval in which measure the performance of my patient? What about the clinical assessment? Which scale should I use? Which CSF biomarker? Do I need CSF dynamics? And then shunt. Should I do an ETV? What about VP shunt, VA shunt, LP shunt? Which valve, which entry point? And again, who is following during time this patient? This is why in 2015, we had the birth of a multidisciplinary team of professionals that was a project on hydrocephalus. It was prospective. It was dealing with prognostic values on the outcome, and it was meant to be pro-patient. So we decided to call it Pro-Hydro. It's a multidisciplinary team. We have a study protocol, and we have many points of multidisciplinary discussion of the cases. You can see this is the flow chart. We follow the patient either if they undergo the operation, either if they do not undergo the operation for several reasons. So the topic here is that we follow patient. We want to follow patient over time. We have an inpatient program. We have an assessment pre-CSF TAP test, 24 hours later, 72 hours later. And of course, we exclude many of them from surgery. And we measure gait and balance, rigidity, bradykinesia, gait impairment. And we follow them pre-TAP test, 24 hours, 72 hours, and the 6 months follow-up visit, and then yearly after the operation. And some of the clinical features are instrumented with the inertial sensor. Time up and go, 18-meter walking step, number of steps, correction during 8 steps at tandem walking, the 1080 assessment tool. Okay, I don't go here into details. This is David, the physiatrist of the group. You see, this is the baseline of a patient of ours in terms of cadence, total steps, total time, double support, gait speed, stride length. And you see that after CSF TAP test, this is the 24 hours improvement. This is the 72 hours. And the green line is the 6 months follow-up. And of course, we have quite an extensive neuropsychology battery assessment. What about the surgery we should perform on this patient? Is it VAS, VPS, LP shunt? Question mark. We still don't know. We still don't know for sure. This is a systematic review. They are very similar, VP, VA, LP shunt, in terms of overall outcome, and they are very similar in terms of complication. I can talk you briefly about my experience. I heard Professor Masakazu Miyajima from Untendo University in Tokyo in 2016. And he said very quietly, patients are more willing to accept lumbar surgery than cranial surgery. I didn't understand very well at the time till I had this devastating complication during one operation. And of course, this was clearly due to the ventricular catheter. And they have, of course, Eastern countries, especially Japan, but not only, of course, have a very clean, a very neat, a very exquisite, I would say, technique with the twine needle, the catheter into the intrathecal space, and completed the VP LP shunt. They were able in Japan through the Symphony 2 trial to demonstrate that LP shunt is useful for this patient, and They were able to compare LP shunt and VP shunt with similar overall results. So this is why I spent some days in Tokyo, and I really enjoyed the company and had useful instruction. Again, my journey in 2017 was touched by this man, Professor Daniele Rigamonti, who came in Bologna, and he told me, listen, Giorgio, you should really think of starting with the ventricular atrial shunting. You can do either by a classical technique of access at the jugular vein. Otherwise, you can use the ultrasound technique. Then I started reading the literature. This paper was published in 2014 by Dr. Mergovern, in which they state that the VA shunting is at least as safe as VP shunting for treating IMPH. This is the series from Professor Rigamonti, demonstrating almost 80% of patients with improvement through VA shunt surgery. And this is the comparison of VA shunt in the recent series from Professor Rigamonti to the previous series of VP shunting. And you can see here that they had definitely less shunt revisions during recent series with VA shunting. This is why in 2020 I decided to try with my friends Raffaele and Bruno to decide I decided to try VA shunting under local anesthesia, and this is what we got. We were able to diminish the hospitalization time, we were able to diminish surgical times, and most of all, we were able to diminish complications that required surgery. A multidisciplinary team approach is a holistic approach. It can improve diagnostic accuracy. It is meant for a personalized treatment. It allows better follow-up, maybe better communication with the patient and the family, and for sure, a standardized evaluation. Of course, there are also cons. There is a complexity, there is an organizational complexity, a possible role overlap. It has high costs and longer waiting times. But to you, young neurosurgeon, I would like to say that this is not a one-man show. We need a multidisciplinary team focused on IMPH. We need young people. We need a young team. We need young people with good relation and collaboration. We must shift the paradigm from cure a patient to take care of these patients. If you have time, please consider to join us in São Paulo in July next year. And I want to thank you very much for having me here. Again, I was and I am very proud and honored to be here in front of you. And I want to thank you very much from the ProHydro team in Bologna. And let's always keep in mind that hope gives life. Thank you very much.
Thank you, Giorgio, for the wonderful presentation. You really covered many topics within the broad field of ventricular pathologies and hydrocephalus. So we have two discussants today. I would like to ask both of them. Maybe we can start with Professor Kurosaki with some comments or questions, and then move to Professor Ashish Kumar. Professor Kurosaki.
Okay, thank you very much for a nice presentation. I agree with you about the problem of the underdiagnosis of INPH. My question is, what do you think about the most important findings? For example, the CT findings DISH or something to diagnose the INPH.
Well, thank you very much. Of course, I couldn't go into every detail, and I decided to focus a little bit more on surgery rather than diagnosis. But honestly, Professor, I completely agree with the Japanese thought that DASH is very, very important for this patient. I think that DASH has a very high predictive value, positive predictive value regarding surgery. So, in many ways, we should be very careful in treating patients with a non-DASH MRI.
Mhm. Thank you.
In many ways, we base our diagnosis on the presence of DASH. Almost every patient in our ProHydro series has DASH.
Thank you very much.
Thank you.
Thank you. And Ashish, maybe you want to give some comments or ask some questions.
Thank you, Alberto. Professor Palandri, it was a great talk. I see a lot of skepticism for shunts for NPH patients. Currently, in the city of Toronto, there is a NPH clinic at Toronto Western Hospitals where waiting period for a patient to see a doctor is around 2 years. So 2 years so that the referral will come from a family physician or a general practitioner to the specialist. They'll be assessed, and when they start to be seen, I think that the assessment will take another year. So these patients start to get very frustrated, and it's an emotional journey for them. So I started doing shunts for NPH, 3-4 years back, just out of frustration, because what happened is that there's a long wait of for patients to be seen. Our neurologist will reach out to you, and most surgeons will not pick it up regardless. So the impact which is needed by someone to do the job is very important. So I think I started doing that and probably have quite a number of patients for NPH. My problem with NPH patients is the assessments for sure. Like I never do it along with it's a combined decision with our neurology team. But I do lumbar tests, lumbar tap tests, and they come back to us. My problem is long term, as you said, 36, only 33% patients or 30% patients, they have long term improvements. My problem is to kind of prognosticate that, and after that, what are the other options once they start, plateauing or stagnating after that initial improvement. In the first year, they'll be very happy. They literally cry, because in Canada, there is a lot of old age population, and we do surgeries up to 80 years, 85 years. It's pretty normal. So that population is very, very, significant here. But I fail to understand how to help them once the improvement starts to, stagnate. And my second question is, if you are using probably programmable valves, what kind of shunt valves you use? Is there any preference? And how long can you downgrade the setting of the valve to make sure that there is no over drainage of the shunt?
Well, thank you very much, Ashish. I mean, that's a new era, a new world is beginning. I mean, when you think of what I completely agree with you. And here in Italy, we have quite the same problems, in the sense that we have, I mentioned that also in the talk, we have a waiting list growing because this pathology is growing due to the fact that we are able to discover it, and due to the fact that of course the population is growing older. So I think this is truly a problem we should ask ourselves as physicians, because we are not able to treat all these people. So I think that there's a political thinking to do around that, how much money we want to spend about that. We need not only, of course, young people, we need also resources.
Yeah.
First of all, this is a comment. Second thing, I think that you were right at the point why we need a multidisciplinary team. When you say they start stagnating, they start deteriorating, because this is the truth. You put the shunt and they have 36 months follow-up, they are stable and so on, or they are even improved, but after that they start deteriorating. So we need a multidisciplinary team. I mean, we need a neurologist, we need a geriatrician, we need a physiatrist. We need to understand why this patient is deteriorating. And I think that our role in this kind of deterioration is quite limited, in the sense that we should rule out a shunt malfunction. First option is a shunt malfunction, and you should, as a neurosurgeon, rule out that this patient has a shunt malfunction. After that, of course, I use always programmable valves, and I think that in the future we will able to publish guidelines in which adjustable programmable valves will be recommended for treating IMPH. So I use the downregulation of the valve with the CT scan at 1 month after the downregulation of the valve. But honestly, I don't see that much result in downregulating the valve. Yeah. So my experience is that I do that. I think we can follow this patient with downregulating the valve, but I think that multidisciplinary team plays a major role here.
Great, thank you so much. And I just wanted to ask about for our young neurosurgeons, some of the pre-shunting parameters which you follow. For example, I know that neurology will follow the gait analysis, the cognitive testing, the MoCA analysis most likely. In terms of the diagnostics test, for example, sometimes the neurology or the lumbar tap test is difficult for patients. Like, what are the other areas, what are the other diagnostic tools you can use, or can you even do a shunt without a lumbar tap test with the help of either the scintigraphic studies or based on CSF flow studies, because these are non-invasive ones and patients will be like, very keen to undergo the non-invasive testing.
Another great question. Thank you very much. To try to be concise, I think that the neurologic evaluation is essential. If the clinical history is clear and clean, and if at the MRI you have dash, an acute callosal angle, focally enlarged sulci, and everything in order, I think that your chance of improvement after a shunt surgery is more than 80%. And maybe you're not improving that much that accuracy performing a tap test. If you see at the series published from Gothenburg, they had the same results in people who underwent the tap test and who did not underwent the tap test, based on the clinical history and the diagnostic images. I think that we should try to reserve that kind of test in experienced hands, in experienced centers, and only for them. Invasive test should be considered to be already a second line assessment. But this is only true for very experienced people. For people beginning, I would say you should have a lumbar tap test in every patient and treat only patients who respond actually to your lumbar tap test. And after that, growing in experience and growing in familiarity in the multidisciplinary assessment, then you can start growing on that. And I think that the Gothenburg experience is really a beautiful example of that.
Thank you so much, Professor. I'll look into that
Thank you.
study which you just mentioned.
Thank you.
Thank you, Ashish, and thank you, Giorgio, for the discussion. I see Sukirti Chawan raised her hand. So, Sukirti.
Hello, Dr. Palandri. Excellent talk. I have a very interesting question. Most of these old patients, they might have had some kind of CVA, like some ischemic injury, or might have had a stroke. So that leads to decrease in the size of the cortex. So that contributes to cortical atrophy plus along with the age. So how much relevance should I give to those ventricles in patients who have had a stroke? What to do?
Well,
because the ventricles look very appetizing to put the shunt.
Again, another very, very good point. These are elderly people. They have lots of comorbidities. And of course, you can think also of amyloid deposits. I mean, that could even render more difficult this kind of surgery with the bleeding risk. I think that really, Sukirti, we should rely on a multidisciplinary team. We should evaluate this kind of patient not only from a radiological point of view, but from a clinical point of view, and keeping in the right account each and every factor. Because, for example, we are now treating elderly people who are on anticoagulants and antiplatelets inhibitors. And this is due to the fact that, for example, they had pulmonary embolism and cardiac stenting at the same time. And they had major strokes, and they are deteriorating after a major stroke. I mean, these are very, very difficult, complex cases. I would say that you shouldn't treat in the beginning those patients. I would say leave them to the neurologist, try conservative treatment as long as you can. But when you get more experience, of course, you can dare a little bit more, especially if you're able to decrease your complication rate during surgery, because the problem is the benefit-risk ratio. So if you lower very much the risk, you can dare a little bit more. This would be my opinion, but I wouldn't do that by myself as neurosurgeon. I would listen to other people at the table of the multidisciplinary team.
Thank you.
Thank you.
Is there any other question from the floor for Professor Palandri? So if there are no other questions, I would like to thank you, Giorgio, for
Thank you.
Nice presentation and very active discussion. I also would have many questions for you, but we have to move on to the next speaker. So I want to give the floor to my co-moderator, Tushit Mevada, for introducing the new speaker. Thank you so much.
Hello, yeah. Thank you very much, Dr. Giorgio, for a wonderful lecture and explanations. Now we are moving to our second part of our seminar. I would like to introduce Dr. Michael Lumintang. He is from Indonesia. He is a consultant neurosurgeon working at Siloam Dirga Surya Hospital in Medan, Sumatra. He is also a visiting doctor at FK University's Methodist at Medan. He has done his Doctor of Medicine degree at Sriwijaya University from Malang, and did a neurosurgery residency at USU, that is Sumatra University, Uttara. He is having a vast experience with more than 20 national and international publications. He is having a good area of interest in neuroendoscopy, neuro-oncology, and skull-based surgeries. And also, I'd like to add that he is having more than 20,000 followers in Instagram for various teaching ways. Today, he is going to talk on about the controversies of the PNET, pituitary adenoma, intracapsular and pseudocapsule-based extracapsular resection in endoscopic, endonasal, transsphenoidal surgery. So I would like to invite Dr. Michael. Mike is yours.
Thank you so much, everyone here. So can I share my slide? Let me share my slide, please. Okay. Okay, now you can see my slide.
Yes, we can.
Okay, the slide is moving, right? Because last I did this, but the slide is not moving. The slide is moving?
Yeah,
okay.
Looks like they are moving, yes.
Okay. Thank you so much. It's an honor to be a part of this seminar. I would like to thank to Professor Giorgio, Professor Alberto Alferti, Dr. Raja, Dr. Thomas, and all committee from ACNS for the opportunity to share. I have no conflict interest to disclose, and I come from Siloam Hospital, Indonesia, with the Center of Excellence of Neurosurgery. This is the picture of Siloam Neurosurgery team from 41 hospitals spread across Indonesia. So I already served almost 29 years for Indonesia, and thank you for the support from the whole team. So my institution is in Medan City, the western part of Indonesia. So we handle various neurosurgery cases for 13 million residents of Medan City. As young neurosurgeon, I started doing mainly brain and skull-based tumor and started endoscopic and keyhole surgery endoscopic. So today, I'm going to share about the controversies of PitNET or pituitary adenoma, intracapsular and pseudocapsular-based extracapsular resection, endoscopic endonasal transsphenoidal surgery. So let's begin with the basic. We know that pituitary neuroendocrine tumor or PitNET are clonal proliferation of hormone-producing cells in the anterior pituitary glands. So they represent a third most common brain tumor after meningiomas and glial tumors, and making up about 10 to 15% of all primary brain tumors. So although benign in the most case, but the location and hormonal impact make them clinical significance. So in 2022, WHO classification, the term of pituitary adenoma was officially changed to pituitary neuroendocrine tumor or PitNET. So for this emphasize that tumor neuroendocrine origin similar to others NET tumor in other part of body. It's important to note that adenoma OMA means are usually benign tumor, meaning they grow slowly, remain well differentiated, and rarely invade or metastasize. However, not all PitNET behave quietly or benign behaviors. Some can show hemorrhage and necrosis, and up to 40% may invade to the cavernous sinus, which cause major morbidity. Long-term follow-up shows recurrent rate between 20 to 50% over 10 years, and highlighting that the need for precise and effective surgical treatment. The question remains, are the PitNET truly benign or potentially malignant. This debate is ongoing, while most behave like benign adenomas, like benign tumor, but some shows aggressive and invasion to surround structure, blurring the line between benign and malignant in neuroendocrine tumors. The gold standard treatment for this is endoscopic endonasal transsphenoidal surgery. But the traditional surgeon perform intracapsular removal, basically internal decompression, like just correct the tumor. But this approach leaves residual tumor tissue and sometimes compromise the normal gland. To achieve true complete resection, we need more refined surgical techniques. So here's the study case. A patient underwent intracapsular ATTS at another hospital, came back 2 months later with still complaint about visual problems. So the option for this patient is observation or gamma knife or anything. So this lesson teaches us that the first surgery is most important opportunity to achieve the total removals. This is a 48-year-old female with visual disturbance and mild headache. She had already undergone 2 prior surgery and gamma knife therapy elsewhere. On examination, with temporal hemianopsia, low ACTH and prolactin level, we perform gross total removal using the extracapsular technique, reconstruct with an inferior turbinate flap. The pathology confirmed that PitNET tumor, and he had transient DI, but no GSF leak and good recovery. So this is the process after finishing. But of course, we know this is the second surgery. There is many septa there. And of course, we cannot 100% trust that we can do total gross removal because a lot of adherence between surrounding structure. Back to 1938, Castillo described that a capsular-like structure surrounding the pituitary tumor is not a real capsule, but a compressed normal tissue performing a boundary. It's called Pseudocapsule. The boundary helps surgeons to identify clear tumor margin, enabling to safer and more complete removals. From the study, meta-analysis shows that extracapsular resection achieves significant higher rate of gross total removals compared to the intracapsular technique, with relative risk of 1.3, meaning that a clear advantage of ER. Similar study for the biochemicals remission, ER again shows the superiority with the relative risk of 1.35 in favor for extracapsular resection. It's means better endocrine control and less need of post-operative therapy. In summary, extracapsular resection offer better result in gross total resection, hormonal remission, and lower recurrent rates, all with the statistical significance. So ER is not just a technical elegance, but is clinically more effective. How about the safety? The study shows that no significant difference between 2 methods, 2 approaches in the term of hormonal deficiency, diabetic insipidus, and CSF leaks. So extracapsular resection achieve better outcome without increasing the risk of complication. This is another example of 41-year-old woman with progressive visual symptoms. We perform gross total resection via pseudocapsular technique, reconstruct with the nasoseptal flap. So there were no major complication. The patient achieved full hormonal remission. So after finishing with the bone bag, we did good enough exposure to get very clear visualize without any blood and something obstruct us to see the border of the tumors. So this is when we did identify the capsules. So start again from behind. Okay, this is we extract the capsule and this is the final views. After that, we closing with the fat flap. So to recap, compared to the traditional intracapsular removal, the pseudocapsular extracapsular approach provide better tumor clearance, better endocrine remission, and similar safety. So in conclusion, pseudocapsule-based extracapsular resection allow more complete tumor removal, improve the long-term remission, and reduce the recurrence with lower post-operative morbidity. Therefore, neurosurgeon should embrace and refine this technique to be a part from of our daily pituitary surgery practice. Thank you so much for every giant and master already contribute to my growth. And thank you so much.
Thank you very much, Dr. Michael, for your very good and informative talk. Hello.
Yes, thank you. Thank you so much. Sorry.
Yes. So I would like to ask Dr. Ashish Kumar for his comments here.
Thank you, Tushit. Great presentation, Michael. I have stopped doing endoscopic surgeries because of the current subspecialty areas which exist in our hospital. But I've done it enough to in the past to understand that identification of the pseudocapsule concept or identification of the pseudocapsule intraoperatively is not easy. So for our young neurosurgeons, what are some intraoperative tips to identify that? Because I gather this is not a radiological phenomena. You don't see that on MRI. But what are some tips which you would like to give to people who are picking up endoscopic surgery to identify that pseudocapsule, which you see is the normal tissue, to get gross total removal of the tumor and minimal residuals?
Thank you so much. Actually, in the beginning, it's difficult to identify the border, the capsule. Even some case, the capsule not yet form well. But in my surgery, I usually to start to study the MRI before the surgery. In this study, I perform a very thin slice of MRI, CIS most, and to identify where is the normal gland at the beginning. So in the beginning of surgery, I already know where is the place of the normal gland. So day by day, when we did more surgery about pituitary tumors, we know we can understand the macroscopic view of the tumor and start to do the decompression and identify the capsule. Sometimes we can identify in the beginning after open the dura, but if we facing some troubles, maybe if you have ICG, some of publications shows that the use of ICG to what I said, we can identify the normal gland with the ICG after the removal of the part of the tumor. I think maybe this is my tip, but I don't know how. If we let's say if we remove more or extra part of the tumor, it means we do something more than usual. In my patient, same like the meta-analysis study, that show that the remission of the hormonals is quite good. So I think maybe not too much worried to do more, even there is like a capsule there, but of course we have to maintain the normal gland. Thank you.
Thank you. I mean, we can probably see normal gland on an MRI with that bright signal on T1, but many times it's very difficult especially for larger tumors, multilobulated tumors, to maintain that clear distinction. But if you're not able to see, do you have any results in your own practice, whether how many cases you were not able to identify, this pseudocapsule you're talking about, and still, you were able to achieve a good resection?
I'm not yet do the study how many patient I can identify, but maybe a lot of patient we can do we can get the identify the capsule, but some of them, of course, is worried to do more. Sometimes we worried about we injure the normal gland and get the more complication to endocrines. But if there's maybe I choosing not to remove too much, but let's see how going on after the surgery. Maybe we need gamma knife operating. But in my point of view, maybe I'm not I don't love to do more gamma knife in my practice, because as we know, if we did gamma knife, the study shows is 40% until 60%. The gamma knife only can like maintain the size of the tumor. Maybe only 40% based on the study can reduce the mass of the volume of the tumor. But after did the gamma knife, maybe if the patient need the surgery, is the difficulties to do surgery again after gamma knife is quite challenging. That's why, of course, this is debatable because this is not true capsules. But I think maybe the tips is when we do the surgery, we have to get enough exposure, so we can sometimes in the beginning of my career, I worried to drill more to the laterals, but now sometimes I did more drill until the anterior clinoid and everything's even day by days. I become confident to do drill more. I think maybe this is, if we can get clear view, I think we can, like I said, insert the endoscopic more deep and more close to the part of tumor. Thank you.
Thank you so much.
I think we can ask about these topics Professor Kurosaki's opinion. He's an expert about that, so maybe we can ask Professor to comment on this, both the extracapsular resection and tips to follow it, and also the role of gamma knife. Professor Kurosaki.
Thank you very much. Thank you very much for a nice presentation, Dr. Lumintang. Kenalkan nama saya Kurosaki. Sama-sama hati-hati.
Wow, your Indonesian is very good.
Yeah, because in my department, one Indonesian neurosurgeon here from Diponegoro University.
Oh,
yeah,
yes.
Ilvan. Anyway,
thank you, Professor.
Anyway, as you mentioned, the identified pseudocapsule in the intraoperatively is sometimes difficult. So I think for the functioning adenoma, functioning tumor such as acromegaly or Cushing, the extra pseudocapsular resection is so important to accomplish endocrinological remission. But maybe you presented a case, second case or third case, I forgot. The a relatively large non-functioning PitNET.
Yes.
It is difficult to identify the pseudocapsule. And maybe after that, the CSF leakage or hypopituitarism occurs sometimes. So in such a case, I recommend intracapsular resection is better, I think, because sometimes difficult to identify the pituitary capsule or pseudopituitary capsule. How do you think about?
Thank you so much, Professor. But mainly, I did the surgery for non-functional tumor. So if we have a chance, correct me if I'm wrong. If I have a chance to do complete removals, it means gross total removals. For non-functional, maybe I think we have to do this because from the study, there is a chance for some of tumors regrow and sometimes grows to 15 to 20% of this case maybe can grows to cavernous sinus. For now, for example, now I have one patient with big tumor is about 4 times 4 centimeters, very big, surrounding the bilateral carotids. And I did the biopsy first to know because this is a chordoma or sometimes, but the pathological results says that this tumor is non-functional PitNET tumor. So I think the important to if we can get gross total removal in non-functional, we can do more. But for functional tumors, maybe intracapsular resection is reasonable because the goals may be only to control the what is it the hormonals and without without decreasing the hormonals and also maintain the function of the nerve. Thank you. Correct me if I'm wrong. Thank you.
And maybe some fibrous tumor case. In such a fibrous tumor case, I think the identified pseudocapsule is easier than the soft tumor tissue.
Yes, Professor.
And as you mentioned, after the tumor recurrence, the second operation, gamma knife is the last chance, I think.
Yeah. Oh yeah, Professor. In your experience, usually you did usually gamma knife after incomplete surgery of pituitary, or you choose to wait and see about some while or some time of observation.
During the follow-up of MRI, some the remnant tumor regrows 3 months or 4 months later. The tumor at first the reoperation, and then after reoperation the tumor recurred again. So I will recommend the gamma knife. The gamma knife is right here, I think.
Oh, the last change, right? Okay, thank you so much, Professor.
Hati-hati.
Tushit, you have to
Thank you so much, Hati-hati. Thank you so much, Professor. I wanted to visit your institution to learn more from you.
I think Dr. Dilshod is having a raised hand.
Thank you. Yes. Hi, everybody. Hi, Tushit.
Hi.
Thank you so much, Dr. Michael, for this interesting presentation. So my question is about follow-up monitoring the patients with non-functioning pituitary adenomas. Usually in case of functional adenomas, we used to give cabergoline to control the tumor growth. How about the non-functional cases? Do you recommend to give cabergoline or just radiotherapy or SRS can be the option?
Thank you so much for your question. Usually, we work here with the teams. Some of my colleagues, they treat the endocrine for me. But for the case of non-functioning, it means the cabergoline and everything is not very effective to this patient. So in my job, my duty is to do more gross total removal as good as I can. But after the surgery, usually we observe the patient, and for the hormonal treatment, usually my colleague only treat the transient pituitary endocrine malfunction, like maybe hypopituitary and everything replacement. But the purpose is not for treat or to decrease or the volume of the tumor. So usually we observe 3 months after the surgery. So we evaluate for the remainings of the tumor and see about the possibility metastasis or invades of cavernous sinus from the tumor and how going on the CSF leaks. And after that, one year after the surgery to detect the recurrent. I think this is usually we do here. Thank you.
Thank you so much.
From the participant group, we have 2 questions. First question is, in the study of intracapsular versus extracapsular dissection of PitNET, was the present or absence of vascular injuries considered as a complication? And if yes, which had the greatest vascular injuries? That is the first question.
Thank you so much. But I'm confused about what kind of vascular injuries is come from hypothalamic artery or from cerebral no from carotid artery. I'm not sure. But usually if we did the surgery for pituitary, usually we no need to expose the carotid artery. So maybe I never get complication for carotid injury. Maybe I'm still young, but I don't know from Professor Kurosaki Tori. Maybe you can share about the complication. But usually, sometimes if we get the complication from pituitary artery, maybe we have to identify the spot of the bleeding. Somehow I'm using endopan bipolar, so it's quite good enough to get right in the tip of the bleeding. So using the endopan from Sator is very good for us. And also if you have flexible bipolars, it's come from Japan company, it's very good to use. Thank you.
And second question is, what was the average size of these tumors?
Average size? Maybe I have to did the study of my serial case, but usually in Indonesia, because the culture here, the patient not frequently screening about their health. So usually patient come with late of I mean very big tumor here. Usually in my daily practice, I get the tumor from pituitary sometimes above 2 or 3 centimeters. Yeah, something like this.
Okay. For the vascular injury part or like that kind of complication, we would like to ask Dr. Kurosaki if he can comment on that.
I'm sorry, what comment? I see injury.
Yes, about IC injuries. Some of the participant asking about there is a chance of injury of ICA or maybe hypothalamic artery or something, pituitary artery.
Because in the cavernous sinus invasion case.
Not sure, Professor, because the participant not asking in specific.
I think the participant was asking whether the intracapsular or extracapsular technique has any impact on vascular injuries. So if there is higher risk of vascular injury using either technique.
Yeah, I know. Vascular injuries may be related to the cavernous sinus invasion. So the pseudocapsular or intracapsular. Of course, intracapsular is safe for the vascular injury, but I'm not so. I think no relation to pseudocapsular or extra pseudocapsular and vascular injury. Thank you.
So I would like to ask my friend, Dr. Alberto, to
yes,
take over for this. Yeah.
Thank you, Tushit. Thank you very much. So if there are no other questions from the participants, I think we can close also this discussion with many thanks to Dr. Michael Lumintang for the wonderful presentation and active discussion, and also our discussants and those who asked questions. I would like to ask Professor Yoko Kato to spend a few words before concluding this webinar. Professor?
Thank you very much. So all the time that we introduce a newcomer, but today we are so sorry about because they went to Kobe for cataract section course till tomorrow. So maybe the next month, I think. So today the two topics is very, very important for especially young doctors. Giorgio, or the nice lecture. Thank you so much. So in Japan, we have so many NPH patients. Maybe some of them is in a nursing home. So no one noticed that they suffer from the NPH, I think. So maybe some screening, those nursing home, I think it's one of the most important things. And sometimes my place is that we do the VA shunt, maybe around 100 cases per year. So VA shunt is a very short manipulation place, and I think most effective so far. My my opinion. I think that VA shunt is need sometimes some technical point, I think, but I think it's very useful technique, and you of course mentioned about that, and also the sometimes NPH is including also the dement, so it's quite difficult to the differentiation of the both. Sometimes dementia patient has NPH. So it's quite even difficult to diagnose by image. So maybe, but you taught us a lot. Thank you very much. And also Mikhail, thank you very much. Still so young, but cross-section sensei, maybe that he will collaborate with your researchers in the future. Thank you so much. It was wonderful webinar. Thank you, Albert.
Thank you very much, Professor Kato, for these comments. Next week, we will have the ISMINS Congress in Vietnam, and I'm sure also these topics will be covered because to be minimally invasive is important in any case, both for IMPH patients. We learned from Professor Palandri many things also about the possibility to use a lumbar peritoneal shunt or a VA shunt, and their comparison with the classic VP shunt, which is more commonly used in Europe. And we learned from Dr. Lumintang about endoscopy for pineal pituitary tumors, and techniques to be more effective and less invasive. So thank you to both our speakers for the wonderful webinar. I want to give a special thank, of course, to my co-moderator, Tushit Mewada. Thank you so much, Tushit. And to our commentators, Professor Kurosaki, Professor Kumar. Thank you for helping us having a very lively discussion. Thank you to our discussants, Biswas, Sukirti, and to all the participants. Thank you so much. And next time we will meet next month with other two exciting lectures. Thank you and have a good day or night, depending on where you are in the world. Thank you so much.